Welcome to the Spirituality and Chronic Pain, the Positives and Pitfalls webinar. We're glad you're here. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD and Pain BC in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. As mentioned, my name is Tanya, and I will be moderating the webinar and handling the question and answer session today. And our presenter today is Dr. Amy Wachholtz. Dr. Wachholtz is an assistant professor of psychiatry at the University of Massachusetts Medical School and a health psychologist on the psychosomatic medicine consult service at the University of Massachusetts Memorial Medical Center. Her current research interests focus on the biopsychosocial spiritual model of chronic pain disorders and the complexities of treating comorbid pain and opioid addiction in both acute pain and chronic pain situations. So I'd like to hand it over to Dr. Wachholtz now.
Thank you very much. And I appreciate the invitation to come and speak with your group. And even though we are scattered far and wide across the continent and potentially the globe, I appreciate everyone who took the time to log in and come to this talk, and I look forward to hopefully interacting with some of you and answering some of your questions at the end of the session. So I want to just start by, we're going to talk about spirituality and chronic pain. Now, oftentimes people consider spirituality and chronic pain, if people have a spiritual background, they often look at spirituality as a very positive thing, and it can be. But there are also points to note where it may not be positive, or it may be more of a hindrance when helping people who are struggling with chronic pain. So in today's talk, there we go. Just want to give a brief outline of what we're going to be discussing. We're going to talk generally about spirituality and health research, so not just chronic pain, but what is the research that led us to our understanding of the interaction between spirituality and chronic pain, because most of this research started in general health. We're next going to move specifically to the biopsychosocial spiritual model of pain. Then we're going to address the major questions that often come up in religion and spirituality and pain research. And just to orient you a little bit to the slide, that R/S, you'll see me use it rather frequently throughout the talk today. It means religion/spirituality. And then we'll also talk about future directions, so areas where we are still trying to find the answers and questions that haven't been answered yet. So let's start with our discussion on spirituality and general health. So the research has shown that spirituality does have a relationship to physical health, and that this relationship can be positive or it can be negative. And that's particularly important to understand, is that there are experiences that help individuals who are struggling with various illnesses, diseases, injuries, and then there are certain coping techniques that are religious or spiritual that actually do not help, that actually can be difficult for that, make things more difficult, more painful, and make the struggles greater. So in a meta-analysis that was done that looked at a number of different studies, what these researchers found is that positive religious coping strategies do relate to positive health outcomes, with a pretty nice effect size. So about 33, that's the effect size, which is a moderate effect size. So we're seeing that individuals that use positive religious coping are likely to have improvement of positive health outcomes above and beyond any medical treatment or other treatment that they are receiving. Further, when people are using positive religious coping techniques, they are less likely to have negative health outcomes. So for individuals that are actively using positive religious coping strategies, we find that these individuals are less likely to have negative health outcomes over the long term. And again, this is above and beyond their medical treatment that they're currently receiving. This is on top of their medical treatment. What we've also found, and this is the area that is a red flag for many people that are working in the medical industry and the mental health industry, is the role of spiritual struggles or negative religious coping. When individuals have long-term spiritual struggles, these often relate to negative health outcomes. So negative health outcomes may be having a heart attack. It might be decreased adherence to diabetes and having more mismanagement of their diabetes. It might be difficulty with adhering to medical recommendations. All of these things that might lead to negative health outcomes. Now, what particularly these researchers found is that short-term spiritual struggles do not necessarily have this effect. However, long-term spiritual struggles, so individuals that feel that they're struggling with their spirituality for year upon year, or may feel that they're experiencing what is sometimes known as the dark night of the soul in Judeo-Christian terms, when this becomes a prolonged struggle, this can have very real, measurable negative health outcomes. So for the most part, when we're looking at religion and spirituality and health, some of the early research is what first cued us into the fact that, hey, this may be a relationship that's worth identifying. It might be a relationship that's worth exploring. So as early on as the mid-90s, some researchers were starting to find in these very, very large epidemiological studies, and with these very large studies, they can't get into complexities, they cannot get into details, but they could ask some basic questions that can point us in the right direction to links between spirituality and health. And what they found was that regular attendance, or attending religious services twice a month, protects health as much as smoking is bad for your health. Now, that certainly doesn't mean go out and smoke as long as you attend church. But what this does mean is that as serious as we consider smoking as a negative health outcome, regular church attendance can protect health. And again, this is after the researchers have already controlled for medical status, medical treatment, and other medical and mental health conditions. After controlling statistically for all of that, they still found that regular attendance protects health as much as smoking is hurtful to the health. Further, later researchers continued to find that regular attendance at church services increases lifespan for approximately 7 years for Caucasians and approximately 14 years for individuals of African descent who are living in North America. So this becomes a very critical component to how people are interacting with their health and using. It's a strong coping technique that individuals are using for their health. And we find that actually prayer for health concerns has gone up through the years. We actually expected to see that prayer for health concerns would be decreasing over time, but we've actually found that it increased over time from 2001 to 2008 using a national survey put out by the Center for Disease Control in the United States that surveyed approximately 40,000 individuals. We actually found that prayer for health concerns increased, and this was regardless of whether or not the individuals had health insurance, regardless of their medical treatment options, regardless of their socioeconomic status. So even when that was all controlled for, we still found increases of use of prayer as a means to cope with health. And what seems to be the most critical regarding the link between religion, spirituality, and health is that it's the behaviors related to these faith organizations, not just cognitions. So for someone who simply thinks, I am a religious person or I am a spiritual person, but that does not actually translate into any actual behaviors, the individual is not as likely to see any protective effects from their religion and spirituality. It's more based on what the individual does rather than simply a self-identity of a spiritual individual. So As I've alluded to briefly before this, I talked a little bit about religious and spiritual coping techniques. So let's go into a little bit more detail of what is positive, what is negative, and what are the different kinds of religious coping techniques. So as I mentioned earlier, we initially thought that there was only one type, and it was all positive. If you were religious or if you were spiritual, it was a good thing and it was always a positive. However, later research really started delving into this in a little bit more complex way and started identifying that there are actually multiple types of religious coping techniques. So later research identified 4 different types. The first type is what is called deferential, and this would be someone saying that they're giving all control of their problem to a higher power. And someone might say it's in God's hands, it's out of my control. An individual from this perspective might say, you know, I can't check, it's not worth checking my blood sugar even though I have diabetes, it is all in God's hands. And it's important to note that this deferring style generally has more negative mental and physical health outcomes. There's more physical disability, there's more anxiety related to this type. There can also be more depression. There's also tends to be more long-term negative health outcomes and negative quality of life with this group. The one exception to this is when an individual is in a very low control situation. So for example, palliative care or hospice care. This is the one experience that researchers have found where differential control actually improves quality of life at the end of life and actually decreases pain and improves coping. But aside from that experience, usually deferential is considered related to negative health outcomes. Collaborative types of coping involve the person saying that they're going to engage in joint problem solving with their higher power. So the person will do what they need to do, and then they assume their higher power will do what they need to do. So someone might say, I've been in a car accident, you know, it's my responsibility to go to physical therapy and keep going to my physical therapy appointments, and my higher power will see me through this. So that's where someone might engage in a collaborative problem-solving style. The next type is independent. And this is where someone says, you know, God is not involved because they have no belief background. They have no current belief system. They just have, you know, they're very neutral on the whole religion or spirituality component. And then at that point they just say, I'll do it myself. I don't believe in God. Now individuals tend to do best with a collaborative style of religious coping across the board. However, individuals that have independence are not far off from the collaborative group. However, one of the largest areas of concern, and when we work with patients that have chronic pain, and something that is a major red flag, is the abandoned type of religious and spiritual coping. And this is when someone would say, I am on my own, I'm doing this on my own because God has abandoned me or is punishing me. And these often relate to much worse negative or much worse physical health outcomes and mental health outcomes. Individuals with this coping style are more likely to experience more pain over time. Their trajectory for pain is likely to go up. Their functional status over time is likely to go down. This is a major red flag of an area of concern for psychologists and physicians that are treating individuals with comorbid pain and this religious coping style. So now let's look a little bit at the biopsychosocial spiritual model of pain. How do we put all of these components into the explanation of what happens with pain? Now there's a number of known influences on chronic pain that's been explored thoroughly in the psychological literature and in the medical literature, looking at the biological factors, the social factors, and the psychological factors that impact chronic pain. what is also starting to be explored is the spiritual factors that also influence chronic pain. And what the research is starting to show is that these spiritual factors have a unique impact on chronic pain above and beyond psychological and social factors. So even once you control for psychological and social factors, you're seeing spiritual factors impact chronic pain on a very different level, which also suggests that psychological factors are not simple, or spiritual factors are not simply another component of psychology, but that they are meaningful factors in and of themselves. And when we explore the role of religion and spirituality in the context of chronic pain, we do know that a number of pain patients do use prayer when they are coping with a chronic pain condition. And not only do they use prayer when coping with chronic pain, but they're also much more likely to use prayer when they're coping with what's called an intermittent pain condition. So this is something that it's an intermittent repeating level of pain. It might have a waxing and waning profile to it, such as severe migraine headaches or severe back pain that has a little bit of a waxing and waning profile. We know that individuals that experience this type of chronic pain condition as well also are very likely to use prayer as a way to cope with their chronic pain. And we know that even over time, prayer use increases with chronic pain. So while some people are less likely to become religious or spiritual due to pain, and that's around 4%, we see a much tenfold increase over that of individuals who are more likely to become religious and spiritual after the onset of a pain condition. So people are much more likely to use religion and spiritual coping strategies and are much more likely to become what they would rate as having a stronger religious or spiritual background after they've been diagnosed with a pain condition. So let's talk about what are the major questions for religion, spirituality, and pain. The first question is, why are there links between religion, spirituality, and pain? So, what are the links, where are they, and why do they exist? The second one is, who uses religion and spirituality to cope with pain? When are people most likely to use religion and spirituality to cope with a chronic pain condition? And how do people choose which tools they will often use to cope with chronic pain conditions? And finally, we want to look at what effect does religion and spirituality have on the different aspects of pain? Because as anyone who's experienced pain knows, there are many different types of pain, and there are many different types of pain conditions. We want to look at how does religion and spirituality affect different types of pain differently. So starting with question number one, why are there links between religion, spirituality, and pain? What are these mechanisms? And this is just a brief outline of a series of theoretical mechanisms that describe how religion and spirituality are linked. In addition to this outline, another reference that I would give you is Kevin Seibold has done some work on identifying some of the physiological pathways through religion and spirituality's effect on pain. This is more of a macro look at how religion and spirituality might affect pain. So as we're up here with spiritual beliefs and practices, we notice there's a number of different ways that we can look at and compare spiritual beliefs and practices, because there's a wide variety of different ways that individuals experience their spirituality, that spirituality plays a role in their life, and all of these things should be looked at separately. Next, this goes into psychosocial changes. So how does the spiritual belief and practices affect psychosocial changes? It changes how people look at their pain. It can change how people feel that they have control over their pain. It creates different levels of social support and instrumental support. And it also offers unique religious and spiritual factors such as spiritual support and growth and additional efficacy beliefs. So both these two, in conjunction with the psychosocial changes, then come down and create physiological and neurological changes. We know that there's altered neurotransmitter levels that occur when someone is engaging in positive spiritual and religious coping strategies. There's different ways that pain is sent around the brain and how those descending pathways affect pain perception. So all of these things then lead to the next area of decreased or altered pain perception. We can get both an increase or decrease in sensitivity or an increase and decrease in tolerance. So when we start with the religious spiritual factors, move to psychosocial changes, see its effect on physiological and neurological changes, and in the end, it creates altered pain perception, which then comes back up here and becomes a self-feeding loop that what happens down here then affects how we view spiritual beliefs and practices. So one of the studies that has come out in support of this, and this is one of a series of studies, but has some really nice pictures that go with it, so I thought I'd present this one. There's a wonderful fMRI study that was asking people how religion or non-religiosity might impact the pain experience. And so what they did is they compared two different pictures. They asked individuals to take a look at two different pictures from the same era and the same style of painting. And you'll see those up in the corner here. And one's an individual of just a woman from the Middle Ages, and one is a picture of Mary. So these were all Christian individuals. And they were asked to reflect upon these different pictures while they were experiencing pain. Now with religious individuals who looked at the religious image reported significantly less pain compared to individuals that were either non-religious or they were religious but not actually activating the religious thought processes during the time of experiencing pain. So for religious individuals who have activated religious sensibilities and religious cognitions may experience less pain intensity. And the reason why they think this has happened is because particularly they showed greater brain activity in the right ventrolateral prefrontal cortex, which is a critical area when we're discussing pain. So these areas, somehow the religious condition activated this area of the brain that then led to decreased pain experience. So the next question is, who uses religion and spirituality to cope with pain? Well, the first group of what the large epidemiological studies show is that the person is older. Now, a lot of the studies are defining older as 33 years old, so you have to take that perhaps a little bit with a grain of salt if you're in your 30s and may not consider yourself as older. But usually they found that people who are over 33 years old were more likely to use religious and spiritual coping resources when dealing with a chronic pain condition. They're more likely to be female. They're also more likely to be educated, so having at least 12 years of education, which in the U.S. Is through the primary school system. And oftentimes these individuals are, again, dealing with chronic health issues such as depression and chronic pain, chronic headaches, back, neck pain. So for some of these individuals, they might have a comorbid depression with their pain, or they might just have a pain condition. But this is a picture of the typical patient that might be using religious and spiritual coping strategies. And as I mentioned before, the prayer and pain has actually gone up. The use of prayer for health concerns has actually increased over the past 10 years. And this is without regard to what somebody's insurance status is, the socioeconomic status of the individual, the patient's age, ethnicity, or their health status. People are just much more likely to use prayer as a mechanism to help them cope with health concerns. And it's important to note that prayer is considered a complementary, not an alternative approach. So people are not using prayer in lieu of standard medical treatment. They're using it in addition to standard medical treatment. So when do people choose to use religion and spirituality to cope with pain? this is often intertwined. These are complementary, not alternative approaches to pain for the vast majority of individuals. And ironically, the first religious and spiritual coping strategy that people are likely to use in response to acute pain, is the least likely coping response to chronic pain. So what research has found is that when somebody has an acute short-term pain condition, a tension headache, for example, what people tend to do is they tend to go reach for the acetaminophen or the ibuprofen in the medicine cabinet rather than taking a moment and engaging in meditative prayer or something along those lines. They're more likely to be very self-directive in their pain management for acute or short-term pain conditions. However, while this is the #1 coping strategy for individuals who are experiencing acute pain or short-term pain, this is also the least likely coping response for individuals who are experiencing chronic pain, at which point most individuals who are experiencing chronic pain are much more likely to engage in the collaborative approach where the individual is saying, I'm going to do my part, my higher power is going to do their part, and we're going to get through this together. And again, as I mentioned, the important thing to note here is it's and, it's not either or. It's not in lieu of medical treatment or in lieu of other types of coping strategies. We're also much more likely to see religious and spirituality used more frequently in the context of terminal illness. So when someone is entering hospice, they're much more likely to use religion and spirituality in the context of comorbid pain. We particularly see this among spiritual and religious groups for whom it is very important for them to have clarity of mind at the end of life, and there's fear that increased opioid use may decrease clarity of mind at the end of life and therefore have an effect on what occurs after death. We also know that religion and spirituality become important in long-term chronic pain conditions, in uncontrollable and intermittent pain conditions, and even when other coping fails and individuals find that religion and spirituality coping techniques are efficacious and they work, people are much more likely to continue to use their religious and spiritual coping strategies and increase their use of those. But now what's important to understand, though, when we talk about people who have religious backgrounds and people who use these religious and spiritual coping techniques is that it's important for an individual who is being encouraged to use these techniques or wants to use these techniques to understand that the use of these techniques needs to come from a faith-based background. It cannot be something that is a technique that gets picked up by somebody who just wants to try it. Because what we found, some colleagues and I did some research with the Flemish Pain League in Europe. What we identified is that when individuals use prayer but they don't really have a faith background, when they're just using it sort of as a last-ditch effort for pain or as a way to test for the presence of a higher power, those individuals actually tend to have worse outcome the more that they pray. They tend to actually have greater pain experiences. So it's very important that individuals who don't believe or don't have a faith background be provided with other coping strategies so that they don't feel like they need to use this as a last-ditch effort, etc., because they're actually going to do worse and have worse pain outcomes. However, for individuals who do have a strong belief system and use prayer frequently for pain management, we do see a notable or significant difference in their pain experience over time. So the next question is, how do people choose which religious and spiritual tools to use when they're experiencing a pain flare or experiencing a lot of pain? And there's a number of different tools that can be used. if everything from prayer, hope, meditation, etc. And again, it's important to note that these are tools, ways that people can use to access their spiritual resources and improve their pain coping. However, like many tools, they can be used positively or they can be used negatively. If anyone has seen a hammer in the hand of an expert carpenter, you'll know that can be a positive experience. Anyone who's seen a hammer in the hand of a 3-year-old may find that that same tool can be a very destructive experience. So what we're really trying to identify is not only what the tool is, but how that tool is used to help people with their pain coping experience. So that's where we need to differentiate between positive and negative forms of religious and spiritual coping. Now over time, positive versus negative have been delineated through empirical validation. So this wasn't something that somebody came up and said, oh, I think this needs to be a positive side because it seems like it would be positive and this would be negative. These are the forms of spiritual coping that have been tested in research and been differentiated between having positive health outcomes under the positive form or negative health outcomes under the negative forms. Okay? So under positive forms that tend to have more positive spiritual, psychological, and physical health outcomes, those include increasing feelings of spiritual connection, spiritual support, forgiveness, positive reappraisal, and collaborative problem solving. Under the more negative forms, and again these are negative forms that have been identified as linked to health declines, poor mental and physical health, and poor health outcomes. These include interpersonal religious discontent. So if you are a member of a religious community, a lot of infighting within that religious community can lead to poor health outcomes. Feeling punished by God, as I mentioned earlier, or feeling abandoned by God can certainly have a negative experience. Demonic reappraisal, so feeling that the individual, God has abandoned them and there's a demon that has cursed them with this pain experience, can also lead to very negative health outcomes. So when we're looking at comparing positive and negative religion spirituality, what we've identified over time is that, again, individuals who have a religious or spiritual background, have a faith system before they were diagnosed, are more likely to have better outcomes when they're using the religious and spiritual tools. Now that doesn't mean that someone can't come to a faith tradition after they've been diagnosed, but again, it's a matter of, do they come to that for multiple reasons, or is it simply that they want to use it as a tool to decrease their pain experience? And that motivation becomes very critical because it directly impacts health outcomes. And as I mentioned, positive and religious coping is associated with positive outcomes among chronic pain patients, and particularly noticing that prayer is the #1 or the #2 most frequently used coping mechanism when dealing with chronic pain. So now this is the next critical component. What effect does religion and spirituality have on the different aspects of pain? As I mentioned earlier, there's a lot of different components of pain, and it becomes important to understand how religion and spirituality may differentially affect those different factors of pain. So the first one is identifying what type of pain is the individual experiencing. Is it acute? Is it chronic pain? Is it acute on chronic? So someone that has, what we mean by acute on chronic may be someone has fibromyalgia and then they get into a car accident. And the car accident pain is the acute pain on top of chronic fibromyalgia pain. So it's important to differentiate what type of pain is being experienced and what type of pain the individual is trying to have treated at that particular moment. Because in conversation with physicians and in conversations with psychologists, it's important to understand which one needs to be the first order of business when you're treating pain, so that you can make sure that you're treating the most important pain to that individual first. And as I mentioned before, the first pain coping strategy is often self-directive, where that over time, as acute becomes chronic pain, it's much more likely to move into a collaborative coping strategy with a higher power. The other component to keep in mind when we're looking at how religion and spirituality affect pain, and even something that if you read in the research literature, it may be a little bit confusing because this study says yes, this study says no, and what does the difference mean? So it's important to understand what are the researchers measuring when they're talking about pain. So sensitivity is talking about that 0 to 10 pain scale, and it's, the 0 to 10 pain scale is endemic in our area, where your pain patients are constantly being asked, okay, on that 0 to 10 pain scale, what's your pain level like at the moment? From 0 to being no pain, 10 being the worst possible pain ever. And that it's not a bad number, but what that says is it's asking you, how severe is your pain? The other question is tolerance or functional level, is what can you do despite having that level of pain? So it's not just my pain is at a 7. The question is, what do you do? What can you still do in your daily life with your pain being at a 7? And what religious and spiritual coping strategies appear to most greatly affect is pain tolerance. There does seem to be some influence on sensitivity that will actually decrease pain on the pain scale as well, dropping people from a 7 to a 5, for example. But the biggest shift that we see is helping people resume their daily lives and resume their daily activities as much as possible, even if there's no change on that pain scale. So helping people get back to being with friends and enjoying their time with their friends, with their family, being able to continue work or go back to work. Those critical components of helping people live their lives seems to be most impacted with positive religious and spiritual coping. And what we've also identified is that increasing the use of this positive religious and spiritual coping can actually decrease medication use over time. So it's not just a matter of does it help with functionality, but also individuals are voluntarily saying, I actually don't need as much medication as I did, and therefore all of the side effects and the costs and the negative impact that it has can actually be diminished as well as individuals return to as best a functioning as they can possibly have. The other crucial component to differentiate is looking at pain versus suffering and what is driving the pain levels. Because in the context of chronic pain, we also know there's a component of suffering. It is more than just the signals that are running up the nerves up your spinal cord to your brain that make you say, ouch. There are a number of different things that impact the experience of pain. So for example, for individuals that have chronic pain, this might be a loss of self-esteem because they can no longer work, depression because they can no longer engage in hobbies or activities that they enjoy. All of these things contribute to suffering, which then can actually make the pain experience worse. And so that, again, it can become a negative cyclical spiral between pain and suffering, each one exacerbating the other. However, just identifying pain without identifying the suffering is not going to lead to positive treatment results. So an individual might be treated with more and more opioids to treat their chronic pain condition, but this may not necessarily lead to a diminishment of the suffering components that go along with chronic pain. It may not go along with the helping with depression. It may not help the person return to work. They may feel increased fatigue and mental cloudiness, and so they're not able to engage in hobbies the way they used to. So simply increasing the opioids will not necessarily treat the suffering component that goes along with it. And so in both treatment and in identifying pain, it's important to understand existential, psychological, and social components that can also impact that pain experience to make sure that it's being treated appropriately. Now, once that differentiation between pain and suffering is identified and beginning to be addressed, there's a number of great intervention studies that have shown really positive impact of helping people use their spiritual resources in the context of chronic pain. So when individuals are experiencing chronic pain, but they're also have the opportunity to engage in some of these spiritual interventions or spiritual therapeutic treatment approaches, we know that it actually can impact physiology. It can change heart rate, blood pressure, fatigue, sleep, mental and physical tension. We know that it can increase pain tolerance, again helping people resume as much as possible of their daily lives. And while some aspects of various forms of secular forms of these treatment components, such as secularized mindfulness meditation, may not be as effective as a spiritual meditation for individuals that have a religious and spiritual background. So for individuals that are engaged in secular pain management strategies, those aren't necessarily bad, but they might be enhanced if an individual would integrate their religious and spiritual practices and beliefs into those coping techniques. We know that when individuals experience or engage in spiritual meditation techniques over something as simple as a 1-month period daily for 20 minutes a day, their ability to tolerate pain goes way up. We know that contemplative prayer can improve mental and physical health and decrease the experience of stress, both physical stress and mental stress. Even something as brief as a single 20-minute spiritual meditation intervention among individuals that have never tried meditation before. So a student and I did this study in the ER with individuals that had never experienced meditation of any kind before. They did acknowledge a spiritual religious background, and they were experiencing severe headache pain. What we found was that a single 20-minute session can make a notable impact on their pain experience. So this can happen both very quickly for immediate results, and with prolonged use of a month at 20 minutes a day, you can see much more prolonged pain reduction experience and much better pain tolerance. So in conclusion, we know that religion and spirituality can impact health in general and pain specifically. Now, by impact, it can make it worse or make it better, depending on how the individual uses their religious and spiritual coping tools. So negative religion and spirituality can increase pain levels, can increase medication use, while at the same time decreasing functioning and quality of life. However, positive religious and spiritual coping on the other side can improve pain tolerance, improve functionality, improve quality of life, while decreasing medication use. So these are very real psychological, spiritual, physical, and social outcomes that can occur from using positive religious and spiritual coping. And the takeaway points really are negative religious and spirituality can be changed, while positive religion and spirituality coping strategies can be enhanced. So thank you very much for your time, and if there's any questions, I will push the questions back to Tanya.
Great. So we did have one person who was inquiring. In the beginning, you mentioned how attending church can have positive health effects in in the opposing way that smoking has negative. Mm-hmm. And there was someone wondering, they have a bedridden condition and can't attend church, and they do a lot of religious practices on their own from home, but wondering if you had any thoughts on does that make a difference if they're not able to actually do the attendance, actual physical attendance piece?
Yes, later research certainly has supported the use of faith-based behaviors, so making sure that the behaviors are something that, keep your spiritual and religious faith close to your heart, make it salient, so it's something that is readily available to you. The one thing that you lose from private faith-based behaviors that's been shown in research is the social support that someone would get from attending like any kind of religious service or church-related activity or synagogue-related activity, temple-related activity. So that would be the one piece that would get lost. And so just making sure that perhaps, if possible, having people over for a prayer group or a group meditation to make sure that you're getting a full, well-rounded experience as much as possible. But certainly there's absolutely no negative effects from engaging in positive religious and spiritual behaviors, even if you're doing it on your own. So absolutely, it can be very helpful.
Very good. And then there was someone else wondering that you use the religious / spiritual throughout the entire presentation, but wondering if there is a difference between the two?
The research field is just starting to try to tease that out a little bit. So in many ways, religion and spirituality research, particularly religious and spirituality and health, is actually a fairly young field. And so in many ways there's still many questions that need to be asked and many ways that we need to better identify this. There is often a research definition of religion and a spiritual definition, or a research spiritual definition of religion, compared to what someone who you ask on the street might say. So someone, if you might ask them on the street, might say, religion is when you go to church and believe in a very specific set of rules and engage in very specific sacraments and do these all in a specific place. Whereas other people might say spirituality is not tied to these to those sorts of rules or regulations. Other times they might say, well, spirituality is the individual practice, whereas religion is the group practice. So there's a lot of definitions that are still need to be pinned down a bit in the research literature. And so that's why in many cases when you read about research in this area, they talk about religion / spirituality, because it's sort of, in some ways, we want to study both aspects, and we're going to kick the can down the road as far as differentiating between the two. So that may not be the ideal experience, but that's where I try to examine if there are differences that have been played out in the research literature, that I make sure to highlight those. But what we're starting to find is that it is much more about the behaviors that an individual engages in, whether they call that religious or whether they call that spiritual, rather than just the cognition of someone saying, I'm a spiritual person, but that never really plays out into any real behaviors in their life. That it's more about what the person does because of that self-image as being spiritual or being religious. It seems to be much more important than just the self-identity.
Very good. And then there were two questions kind of related to your research as a whole. Wondering what the proportion of sample sizes were for non-religious / spiritual versus religious / spiritual people, and as well how findings vary over the duration of chronic pain.
So with different sample sizes, obviously there's different levels of groups that we bring in. As much as possible, we try to match the local demographics of the groups that we're working with. So we try to match them on religious spirituality, we try to match them on ethnicity and cultural background, and we try to match them on gender as much as we can. So for when some of the research is being done in more heavily rural Christian settings, we're going to see a more heavily Christian population. When we're working in a more of a city population, we're going to see a much better representation by individuals who come from Buddhist traditions, Taoist traditions, Hindu traditions, and so a wider variety of religious and spiritual traditions. When we're working in Europe, such as with the Flemish Pain League, again, we try to make our sample size balanced with what the European demographics are as far as religious versus non-religious individuals.
Very good. Someone was asking if you could speak to people who have negative religious/spiritual coping practices, particularly those that have use phrases like "God is punishing me" or "this is my fate," and what are some helpful interventions to redirect to more positive religious spiritual coping?
And that I'm glad that somebody asked that, because it really is when you hear whether you're a professional or whether you're a friend or family member or colleague of someone who is making statements like this, it really is a red flag for declining health and more negative outcomes. One of the best recommendations that I can give is to find a psychologist that is comfortable working with spiritual and religious issues, or sometimes you can find a pastor of a church that also has training and background in spiritual direction, or they might have like a master's of counseling in addition. So somebody who can work across both mental health lines and spiritual health lines is critically important. And oftentimes what is involved in that kind of treatment is going back to the beginning and exploring where does that negative image or that punishing image of a higher power come from? Does it come from a simple life event? Does it come from a traumatic experience that then has changed how a person views their higher power all along the way? If someone is looking at a kind, caring, or loving higher power to other individuals, why are they suddenly punishing this individual? Are there other ways to seek forgiveness so that the person feels like they aren't being punished? They can make amends through other ways, and they can make amends through other ways so that they don't feel like they are being punished, but instead are feeling like they're being supported. So there's a number of avenues that therapy such as this can be taken, but particularly going back to identifying what was the original event where the individual came to believe that they were being punished or being abandoned by their higher power, and are there other ways of making amends for that initial event.
Great. And then there's one more, someone asking if in your studies or in other people's studies, if people looked specifically at the content of the prayers, like what people were saying, like faith-based versus non-faith-based prayers, and whether that mattered at all if it was looked at.
Some of the prayer studies that I reported on, there's one particularly by Lucin and I think that I mentioned towards the end, where we use like a mantra-based prayer, so using almost a standardized prayer. Sometimes other studies will use something like, if there's individuals coming from a Catholic background, they might use the Jesus prayer, or they might use rosary prayer. If there's very specific, or when people are studying Islam, they might be using specific Islamic prayers. So it depends a little bit on whether the prayer study is studying very specific unified content. There's also other studies that have identified there's 5 different prayer types, and whether that's praising prayer, asking for a prayer that is asking for help for themselves, asking for help for somebody else, those have been categorized as well, not in relation to pain that I'm aware of, but those prayer studies are being done just in asking questions about prayer. Again, I'm not, aside from the prayer asking for one's own health concerns. That was the large epidemiological study that I did with Usha Sambamthuri in the United States. I'm not sure that anybody's looked at content of prayer or how prayer has been asked for yourself, but those studies are coming, and those studies are starting to be done in the strictly psychology of religion studies. They haven't been applied to health yet, again, as that I'm aware of, but those questions are being asked in the very early stages in the psychology of religion research literature.
Very good. And then I think that's about it. I did just get one longer question, but I think I might just email it to you. It's a little more complicated than I think we have time to get into. So I think that was a really great presentation. Thank you very much. I had no idea that most of this research was going on, so I think it's really intriguing and interesting and can be very applicable to a lot of the people who do suffer with chronic pain and those who live with them as well as treat them. So I think it's really great. Thank you.
Oh, my pleasure. Thank you for inviting me.
Absolutely. And thank you everyone for joining us on the webinar today.